is a 65 years old male with a pancreatic adenocarcinoma with portal vein thrombosis and mesenteric artery involvement and liver metastasis. He has had a dorsal pain with opioids and now will be submitted to a U.S. guided neurolysis.
Good morning, everybody. Thanks again to Marc for having me here. It's really always an amazingly well-organized meeting. So to intubate, first of all, this is the therapeutic scope. Pentax has the new slim scope. For neurolysis, I use a 19-gauge needle, so it's a little easier to put the 19-gauge down the therapeutic scope. But if you need to, you can use the slim scope as well. For me, I use the balloon primarily for safety reasons. I think it makes it easier to intubate and to go around D2. So when I intubate, I keep the balloon quite large, okay? So you want to put the tube in the back of the throat, okay? And I kind of look at the ultrasound and see the tongue, and I put my tip down till it goes behind the tongue. Then I put the patient's head forward. Where's the endoscopy? And I just push, and in we go, okay? So most of the times it goes quite nicely, even with the large scope. So to me, the easiest way to find now what you're looking for is to start at the liver. So when I go in, remember the buttons are facing the probe is on the same side as the buttons. Yes.
Anna, can I just ask you, is that the new ultrasound machine?
The new what, sorry?
Is that a different ultrasound machine? Which one have you got?
No, this is the old. This is the Praeris, Ascendus. Yeah, it's not the Arietta. Okay. So I start in the center of the liver. Here's one end of the liver. Here's the other end of the liver. I want to be in the center. Again, I'm going to torque, and all the way with you can do with one arm. Torquing with my arm, the vein is going to come out here. Now, and the problem with this guy is that his vein is totally encased by the tumor, so it's in here somewhere. If I keep torquing, you'll see here's the sort of part of the mass. Here's the obstructed pancreatic duct coming out of the tumor. And I keep torquing out to the tail, okay? And then when I teach, I tell the fellows, once they get out to the tail here, you should always, when you're alone, try to follow the tail all the way out, the duct all the way out to the tail. But for teaching purposes, I say, once you get out here and you see the kidney, pull to the edge of the kidney, tip up, go left, you'll see the adrenal sort of in here. And if you keep going left, you're going to see the aorta. And if you keep going left, you're going to see the celiac. So here's the celiac, here's the SMA. So we're doing neurolysis in this gentleman, which is what's good here is that his celiac is clear. Okay, there's no tumor encasing his celiac, which makes life much easier. Okay, if there is tumor, involving the celiac, you can still try and do neurolysis. It can be difficult to, I just kind of try and I as you know, I favor the bilateral approach. So I want to get, there's ganglia all the way down to here. Okay, the ganglia aren't here or just here. They really go from here all the way down to the base of the SMA. So I want to try and distribute drug all the way down here. Okay.
Do you try to identify the ganglia?
I don't try to identify. I think it's a waste of time. I think that this idea of injecting the ganglia. Here's some ganglia here. You can do that, but these are very small. So if you're injecting 10 cc's or 20 cc's of alcohol, this ganglia is just going to explode. And the alcohol is going to go all around it. So with my approach, even though I don't see the ganglia, I'm probably going through some of them anyway, and then I'm pulling back and distributing drug all around that area. In my opinion, there are no data showing that injecting the ganglia improves efficacy. I know there's one trial, that, yes. but if you look closely at that trial, what they did was they compared injecting bilateral to injecting just at the base. So what they basically did was they compared bilateral to central. They didn't compare bilateral with ganglia versus bilateral without ganglia, that's what you need to do. And what they basically showed was that the bilateral approach was better than the central approach. So they proved, if you ask me, the idea that the bilateral is better. Now, Mike Levy, I keep saying this at the meetings, has done a study where he compared injecting bilaterally versus injecting bilaterally plus the ganglia. And if you look on clinicaltrials.gov, the study was finished about 2 years ago, but there's no data yet. So I don't know what's going on there, but the study has been done. But I suspect that they will not find a difference by doing bilateral versus bilateral with ganglia. So I just go deep to the base here, deep to the other side. And the reason I started talking about this was that if there's tumor involvement here, and I basically can't see or put the needle anywhere here, then I will just do a central or, put some drug where you can,
It will diffuse anyway.
Yeah, exactly. So what I do is I take only a 19 gauge needle. I do not believe the side holes on the I don't think it makes a difference.
Needle, yeah.
And that needle is a little less sharp. It's a little more harder to inject with that needle because it's a 23 gauge needle. 19 is very easy to inject. And I use only alcohol, no bupivacaine. I think putting the bupivacaine, we put the bupivacaine, it's more for us, not for the patient. It makes us feel like we're doing something to relieve the pain. But in real life, I think the bupivacaine only dilutes the alcohol. And my goal is to get as much concentrated alcohol on the ganglia as possible. So we've actually just started a randomized trial of alcohol versus alcohol and bupivacaine. And that's going to take a while to do. We just started it because we need to randomize about 100 patients. But hopefully we'll have an answer to that question fairly soon.
Do you ever inject steroids?
No, steroids I only use for chronic pancreatitis.
For chronic pancreatitis.
So we're currently doing a randomized trial for chronic pancreatitis. And that study is showing, to my surprise, some benefit, but that's another issue. So we're going to take the needle.
Anand, could you just show the celiac artery again? It's a nice little fusiform aneurysm.
Yeah, she has a little aneurysm,
celiac artery.
Yes.
Yeah.
You can see it right here.
Extremely common, actually. We see it more and more when we're doing this. It's a very common phenomenon.
Yeah, I'd say it's about 1 in 20, I guess. I don't find it that often, but it's there. It's there. Okay, so if you notice, she gave me the needle with the stylet back in. So I take the stylet out, on enlève, tout de suite. Oui, c'est ça. So because I preload the needle with the alcohol, I see no reason to inject saline first, and if you have the stylet in and then you're putting in the alcohol, you're going to put some air into you don't want that. So I just preload it with the alcohol. Fait qu'on va juste injecter juste un petit peu. And you got to be very careful. This is pure alcohol, so you don't want this getting in people's eyes or anything. Okay. So I'm just going to lever ça. So I have some trouble. Sometimes the 19 doesn't come out in front of the elevator. I don't know why. So you got to put the tip down and just make sure okay, I can see the sheath very well. I pull the sheath all the way back. Okay, so I'm back here. Okay. The nurse is allowed to come. Okay. So and the other thing I used to do is I used to get both vessels in view, put the needle in, then turn to the side, go down here, then come back, then turn back, and then go to the other side and go like this. But what I've decided to do now is I think it's easier actually to just, with the needle still not introduced, to turn to the side, go through the wall, and then come out. I'm not concerned about going through the wall multiple times because this is pure alcohol. It's all sterile. The other thing we know is this guy has portal vein thrombosis, and it looks like he has a few little vessels here. Just for the fun of that, we'll put that on. No? Yes.
Oh, yes. Yeah.
So it's probably not a good idea to go through those vessels. There's no data to support that, but I would probably not want to go through. So I'm just going to put the needle out. I can see the tip. It's pointing straight at the vessels. So I'm just going to sort of find a way to get past them here, if I can. This is a little better here. So I'm going to go through the wall here. Then I'm going to pull back. Okay. And I'm not getting very deep here. I want to be a little, I really want to put the drug closer to the aorta here. So I'm going to go a little deeper. There we go. Okay. So now, no, attendez. So now I'm here. I'm going to go a little deeper. Okay. And then I'm going to turn to the side. Now I'm going to go quite deep here. And I don't see the needle that well, but I kind of know where it is. She's going to aspirate. On va aspirer. At live courses, there's always some blood. Go. Okay, c'est bon. Okay, so she's going to inject. So she's going to inject. Doesn't have to go slow or fast. I think slow is okay. And this patient is under propofol, so he's not really moving. We just have Versed and fentanyl, and usually when you're in the right place, you get the the patients get quite a lot of discomfort. So now I'm going to pull all the way out. Okay.
That's the rationale for bupivacaine.
Yeah, but I find that even though our patients have some discomfort on the table, by the time they get to recovery, they're okay. And because of the Versed, they don't really remember. So,
That's right.
so I don't think it's a big issue. So I've done this side. Now I'm going to come back and I want to do this side. Now this side, I used to go really deep in here, but it's a little more, I don't like to go, most of the ganglia, in my opinion, are on this side. So when I do this way, I do kind of more just in here. So it's kind of a bit more just central and just a little bit to the base of SMA. I don't try and go way down here. I just don't feel comfortable going way down here. I'm not quite sure what's going on over there. So I've done this side. I'm going to come back here. I'm going to put my needle back in. Okay. Just kind of in here. Pull back a little more. Excusez-moi. Right about here. She's going to aspirate again. So this is actually just more kind of at the base. Okay, on y va.
So this is the position of the classical central injection.
So it's kind of a bilateral answer. You do want to cover the central ganglia as well, but I really want to get more drug at the base, and that's basically it. Now, if you notice, there's quite a blush here. Okay, this is what you get with the alcohol. I don't know if anybody's ever tried with. C'est fini, hein? C'est les 2 fois les 20. Ouais, ouais. I don't know if anybody's ever tried with phenol, but we had phenol for a while. Phenol is very interesting because it doesn't cause any pain when you inject, and it also doesn't cause any blush. So it's actually an interesting agent. We just couldn't get it anymore. But I think we need to do some studies maybe to see if the phenol is just as effective as the alcohol. I would also say that, and you can see it's a little hazy here, I always do a little Doppler just to show that everything's still permeable. But even if it wasn't, there's nothing I could do. But we did have one case of infarction and death after neurolysis. It was a weird case where many different vessels got infarcted. But you do get a little bit of a haziness here, which shows, I think, that we're in the right place. But it would be interesting to see if phenol was of any help. I don't know if we have any more time. Mark wanted me to do an FNA of this liver lesion here because there was a question mark of a renal cancer versus a pancreatic cancer. So we'll do an FNA. Je prendrai une aiguille 25, pas de stylet. No, avec le stylet.
While you get the needle, in
Avec le
case
stylet,
there is a
excuse.
very thin patient and the area of interest is very, very small, do you recommend or do you often inflate or inject normal saline to
Never.
buff this area up
Never.
before you put the alcohol?
Never.
Because some people do that, and I don't really find it very helpful.
No.
No, you don't need to. Just turn the scope away to find a place where you're further away from the aorta, and then turn back. So we're going to do a liver FNA. So I am very unfavorable to the stylet, as you may know. The only time I use the stylet is if I'm doing liver FNA, because as you know, liver tissue, normal liver, causes problems for the cytologist. So I think it makes sense to try and avoid getting normal liver tissue in the needle. And that's especially true if it's a deep liver lesion. Now, I have no data to support that, but I think if in the randomized trials of stylet versus no stylet, they had selected out just liver lesions, they might have seen a difference with the stylet. There might be a little bit of an advantage, but even there, I'm not sure. I also keep the stylet if it's a pancreatic lesion, but there's a lot of normal pancreas. For example, a small neuroendocrine tumor, and I want to avoid getting normal pancreas in the needle, then I'll keep the stylet until I get inside the tumor. So here's the one lesion here. Okay, I lock my up down, put this guard down. Again, you want to hold the needle. With this needle, the stylet is flush with the tip, so you don't have to pull it back. Okay? You want to hold the needle with just 2 fingers, not like this, not like this, not like this. This way you get good control, okay? I tell the fellows to put the needle out just 1 centimeter till you see the tip. There's the tip. Then with the liver, you don't want to be scraping up against the capsule too much. So once you see the direction you want to go, just go in and stop, okay? And once you're in, then we're going to remove the stylet. Voilà, tu peux l'enlever, ouais, okay? And so now I want to stay inside the lesion, and I'm going to move the needle back and forth. No, pas de suction. So for FNA, now not for biopsy is different. For FNA, suction just gives you more blood. It doesn't improve the yield, okay? So I'm just going back and forth, and I like to, instead of fanning, where I stay in and move around somewhere, I actually come out, and I move, but stay in the liver, then move over with the elevator and go somewhere else. Okay, we should maybe zoom in a little bit, you'll see that a little better, okay? So I'm coming out, and I'm going somewhere else, up in the top now, okay? And I say with the liver, you want to kind of stay out of the normal liver if you can, because it confuses the cytologist. So I come out again, move over, go somewhere else. Okay? Come out, move over, go somewhere else. I think it's really important to come through the edge of the lesion in a different place. This, to me, means that you're getting automatically new tissue every time you go somewhere. Okay? So doing this technique, no stylet, no suction, although we did use the stylet in this case here, our first pass yield is over 90%. Okay? So it's just as good as anybody else's, if you ask me. And so which to me means that really the suction and all that is not really necessary. Ça, on va le mettre sur des lames ou dans un, pour la cytolite? Okay, so we're doing a cell block here. Now for cell block, I do use suction, because for cell block, blood doesn't matter. On va mettre un petit peu de suction, finalement. Oh, oui. Okay, for cell block, I do use suction, because you want to get as much material as possible. You don't care about blood, because the blood will be spun away. Okay, and remember that with a 25 gauge needle, it takes a good 30 seconds for the suction to actually get to the tip of the needle. So you have to do it actually quite a long time if you want the suction to be of any value. Okay, so I think we've been in here for quite a long time, so we'll take this out. So with liver FNA, what's interesting is you can tell if it's positive just by looking at the sample, because if the sample is white, then it's got to be tumor, because the liver, as you know, is all blood. So if we look at this, I don't know if we'll be able to see it, but if it comes out pretty much white, then we've got just tumor.